We start very quickly the session dedicated to end-stage liver disease and transplantation. My name is Richard Moreau. I'm working at Beaujon Hospital, and François Durand, my co-chair, is also working at Beaujon Hospital. And he will be the first speaker. His talk is entitled Management of Patients with Decompensated Cirrhosis. François Durand is a professor of medicine, head of the liver unit at the Beaujon Hospital. François, please.
So thank you for the organization committee, and a special thank for Patrick, who organized this nice meeting in Paris. So I'm going to talk about decompensated cirrhosis. Those are my disclosures. So decompensated cirrhosis is a severe condition with a high mortality. It is a challenging situation. You can see here the rate of transition from compensated cirrhosis to decompensated cirrhosis over time, and the rate of progression from compensated cirrhosis to death and from decompensated cirrhosis to death. And the probability of dying is, of course, much higher in patients with decompensated cirrhosis. On the right, you can see here that mortality rate is significantly higher in patients with decompensated cirrhosis, and the difference between patients with compensated and decompensated cirrhosis appears very early. So again, this is a difficult condition. So I could speak for during hours of decompensated cirrhosis, but I will focus my talk on four topics: bacterial infections and resistance to antibiotic in cirrhosis, albumin and bacterial infections in cirrhosis, acute kidney injury in cirrhosis, and management of refractory ascites. Well, bacterial infections are very common in patients with cirrhosis in general, and even more common in patients with decompensated cirrhosis. We know that bacterial infections are associated with a high mortality rate in these patients because this is a trigger of organ failure, which can lead to ACLF. There are a number of studies which have shown that bacterial infections are associated with a worse prognosis in patients with cirrhosis. You can see here the results of a meta-analysis confirming the impact of bacterial infections. An emerging problem is that of multi-drug resistance infection in Europe as well as in the rest of the world. This is a very recent European study which has been promoted by the CLIF, showing the distribution of prevalence of infections, culture-positive infections, and multi-drug resistant infections in three parts of Europe: Northern Europe, Southern Europe, and Western Europe. As you can see, the prevalence of infections was similar in the different parts of Europe, but culture-positive infections were less common in Southern Europe, and multi-drug resistant infections were also less common in Southern Europe as compared to Northern Europe and Western Europe. But multi-drug resistant infections in general had worse prognosis as compared to other infections. If you want to have a more global view, this is a very recent study which is in press, which has been promoted by the International Club of Ascites with Salvatore Piano, exploring the distribution of infections in America, North and South America, Asia, and Europe. As you can see here, the most common infections in these patients were urinary tract infections and spontaneous bacterial peritonitis. Gram-negative infections were more common in Asia as compared to America and Europe. Multi-drug resistant infections were also more common in Asia, as well as extended criteria infection. And in this cohort, multi-drug resistant infections were also associated with worse prognosis. So this is a real burden. So a way to avoid mortality related to infections in patients with decompensated cirrhosis is, of course, to prevent infections. And one of the ways to prevent infection is long-term administration of norfloxacin. Several studies have been conducted with contrasting results, and I show you the last study, which has been conducted by Richard Moreau here. 291 patients with child PHC cirrhosis, who were randomized to receive norfloxacin or placebo. And in patients with ascites and low protein concentration, the administration of norfloxacin was associated with lower mortality, and the difference was significant. And in parallel, patients receiving norfloxacin were at lower risk to develop infections during follow-up. So this is an encouraging result. And interestingly and very importantly, in patients receiving norfloxacin in the long term did not had higher risk to develop infections with multi-drug resistant bacteria, probably because the mechanisms leading to resistance to quinolones are different than mechanisms leading to resistance to other antibiotics. So now let's move to albumin and bacterial infection. We are all living with this old study, relatively old study, which has been published in 1999, and which showed that in patients with spontaneous bacterial peritonitis, concomitant administration of albumin could be associated with less renal impairment and improved survival, reduced in-hospital mortality and reduced 3 months mortality. And now it is widely recommended to give albumin in combination to antibiotics in patients with spontaneous bacterial peritonitis. But please note that this is a single old study, and that the number of patients who have been included in this study is relatively limited. Following this study, there have been other studies in patients with non-spontaneous bacterial peritonitis infections with contrasting results. I just present you here one of these studies coming from France with 2 groups of patients, almost 100 patients in each group, with non-SBP infections and randomized to an antibiotic plus albumin arm versus an antibiotic alone arm. The age of the patients was similar. Most of these patients had cirrhosis related to alcohol. MELD score was quite high. The main causes of infection were pneumonia and urinary tract infection. But in this study, the authors failed to show a difference in terms of survival between the albumin plus antibiotic and the antibiotic alone group. There is another study coming from Spain showing the same results and meta-analysis which show a possible benefit in a combination of antibiotics. Now, these contrasting results have been challenged by a very recent study published in the Lancet, which has been already discussed during this meeting, exploring the potential benefit of long-term administration of albumin in patients with decompensated cirrhosis. A large cohort, more than 400 patients, randomized to albumin for up to 18 months compared to standard medical treatment. And in this study, long-term administration of albumin was associated with a better prognosis. As you can see here, mortality was lower in patients receiving albumin. And in patients receiving albumin, spontaneous bacterial peritonitis was less common, and the incidence of non-SBP infection, impaired renal function, and type 1 hepatorenal syndrome were lower. So now we are faced with a kind of paradox, because we have an old evidence that albumin plus antibiotics are superior to antibiotics alone in SBP. We have no clear evidence, or we had no clear evidence, that albumin plus antibiotics are superior to antibiotics alone in bacterial infections other than SBP. And now we have very recent evidence that albumin may improve survival in patients with decompensated cirrhosis, and that this improvement in survival is at least in part due to decreased rate of bacterial infections other than SBP. So all of this will have to be clarified. Now, acute injury in cirrhosis. Well, acute injury is common in cirrhosis. This is another cause of mortality. The incidence of AKI can be up to 19–20% in hospitalized patients with cirrhosis. And we know that the progression of AKI is associated with a higher mortality. There are some difficulties in the diagnosis of AKI in patients with cirrhosis because serum creatinine overestimates GFR. Urine output is poorly informative because, especially in patients with refractory ascites who are frequently oliguric. There are different phenotypes of AKI with different prognosis and a need for early initiation of specific therapies in specific phenotypes, and I think about vasopressors in hepatorenal syndrome. So the criteria for the definition of AKI in cirrhosis had to be revised. These criteria have been revised recently with the EASL and the International Club of Ascites, and now the objective is to recognize AKI at an earlier stage. And now the definition of AKI in cirrhosis is a modest increase in serum creatinine, more than 26.5 micromole per liter within 48 hours, or an increase in creatinine of at least 50% within 7 days. Then hepatorenal syndrome has been incorporated as one of the phenotypes of AKI in cirrhosis with the following criteria: ascites, no response after 2 days of volume expansion with albumin, no recent use of nephrotoxic agents, and no evidence of structural kidney injury. And then there are the other phenotypes which are frequently observed in cirrhosis: prerenal failure and acute tubular necrosis. Other criteria that I will not develop help stage AKI and determine the progression according to response to therapy. It is important to identify patients with HRS AKI at an early stage because these patients should receive terlipressin. And criteria consisting in 2 days of expansion with albumin before starting terlipressin maybe should be challenged in the future because it delays introduction of therapy. Terlipressin can be administered either as boluses or with a continuous infusion, and whether one or the other of these options is superior has been a matter of debate. So we have now a recent study, an Italian study, comparing continuous infusion of terlipressin in patients with hepatorenal syndrome to intravenous boluses. These patients had a high MEL score, it is not surprising, a high level of serum creatinine, a similar response rate, similar mortality rate, but the difference is side effects, which were less common in patients receiving continuous infusion. So this option should be preferred to boluses. Now the last part is the management of refractory ascites. TIPS is one of the options in refractory ascites. There are several studies showing that TIPS is effective at treating refractory ascites as compared to medical management, but most studies did not find evidence of lower mortality in patients receiving TIPS as compared to large volume paracentesis. These data have been challenged by a recent study conducted by the Équipe of Toulouse in France. 62 patients with at least two large volume paracentesis within more than 3 weeks. And these patients were comparable in terms of age, cause of cirrhosis. Alcohol was the leading cause of cirrhosis, number of paracentesis on MEL score. And in this study, there was a clear survival advantage in patients receiving TIPS. So these results are interesting, but first, severe ascites is different from refractory ascites, and second, these patients had a low MEL score because TIPS is contraindicated in patients with a high MEL score, which is a serious limitation. So we had TIPS, and now alpha pump is an emerging alternative to paracentesis in patients with cirrhosis and refractory ascites. So this is the principle. You have two lines which are inserted subcutaneously. One line which is in the peritoneal cavity and the other line in the bladder. So the ascites is pumped with a system which derives ascites in the bladder, and ascites is eliminated with urine. We have small preliminary studies comparing alpha pump to paracentesis. You can see a relatively limited number of patients. The MEL score was low in this study. Infections were comparable in the two groups. There was a trend to higher serum creatinine in patients treated with alpha pump, at least at the beginning of the treatment, but the difference was not significant. The main difference is that the number of paracentesis was, of course, lower in patients treated by alpha pump, and the quality of life was significantly improved. So it is an emerging option which may be efficient in patients with refractory ascites, and trials are needed to know if there is a survival benefit. So to conclude, decompensated cirrhosis is still associated with high mortality rates in the absence of transplantation. Bacterial infections are a major source of mortality. Multidrug resistance is common in Europe and even more common in Asia. Long-term administration of norfloxacin may improve survival in patients with ascites and low protein concentration without increasing the incidence of multidrug-resistant bacteria. Long-term administration of albumin may improve survival in patients with decompensated cirrhosis, but the role of albumin in non-SBP infections needs to be clarified. An issue is whether norfloxacin plus albumin could do better than each of these two options. TIPS may improve survival in patients with persistent ascites, but it needs to be confirmed with current techniques and cover TIPS in patients with refractory ascites. But unfortunately, the use of TIPS is limited by encephalopathy and disease severity. Patients with a high MEL score may not receive a TIPS. Alpha pump could be an alternative to paracentesis or TIPS in patients waiting for transplantation. Thank you for your attention.
Thank you, François, for this outstanding lecture. I suggest to club the questions at the end. Now
it's my pleasure to introduce Dr. Adrian Guedano from Buenos Aires, Argentina, who is going to talk about optimal management of portal hypertension. Adrian.
Thank you very much, Richard, François, and special thank for Patrick Marcelin again for inviting me to this outstanding meeting. So this is my disclosures concerning this issue. First of all, to begin this lecture, I want to strengthen the importance of staging these patients, a patient with portal hypertension, into one of these two different stages of cirrhosis. What I want to say is that it's very different a patient with portal hypertension in a compensated phase of cirrhosis than in a decompensated phase. So this is very different concerning risk stratification and the individual care of these patients. So this is the first thing we have to do when we face a patient with portal hypertension. Also, in compensated cirrhosis, we can find patients with mild portal hypertension. So in these patients, the portal pressure is less than 10, expressed by the hepatic venous pressure gradient. Or we can have a patient with clinically significant portal hypertension where the portal hypertension raises at 10 or over 10. And this patient may have no varices or may have varices, almost half and half of these patients. So we have to do this split when we see a patient and stage the patient in one of these categories, because if the patient is decompensated, the risk is of more complications or even death is much higher. And on a pathophysiology point of view, very rapidly, you know that there is increased hepatic resistance at the beginning, and this is followed by increased portal blood flow, which is a consequence of splanchnic vasodilation and hyperdynamic syndrome, resulting in portal hypertension, collateral circulation, and varices. At the first stage, when there is subclinic portal hypertension, so the gradient is from 6 to 10, there is only probably mainly resistance to portal blood flow in the liver. There are very thin septa, or maybe there is no cirrhosis at this stage, but advanced fibrosis. But there is also already a functional component in these patients that may play a role. The aim in these patients will be, with already portal hypertension, will be to only to intervene over the etiology of the liver disease, for instance, treating hepatitis B or C or alcoholic liver disease, or treating NASH, and to prevent the outcome to the following stage, which is clinical significant portal hypertension. If we cannot achieve that, resistance to portal blood will increase, splanchnic hyperdynamic circulation will occur, and patient will reach more than 10 millimeters of portal pressure and will achieve the stage of clinically significant portal hypertension. And this is a different patient, which is more fragile and a patient that can develop severe complications of cirrhosis, ascites, bleeding, encephalopathy, hepatocellular carcinoma, infections, etc. And this is associated, of course, with a higher mortality rate. And you can see here in these couple of studies that patients with HVPG more than 10 have more clinical decompensation and more development of hepatocellular carcinoma. And of course, more than 10 of portal pressure is associated with increased mortality. So the main objective in this stage will be to prevent the development of complications and to reduce death. So gastroesophageal varices develop in approximately 40% of patients with compensated cirrhosis and in up to 85% of decompensated. So this is very different also between these two stages. The incidence of first variceal bleeding is about 30%. And the mortality in this first episode ranges from 10 to 25%, again, depending on the patient. The variceal rebleeding rate is 60% at 1 year, and mortality in these patients is much higher, about 50%. So how can we intervene in these patients with different tools that we may have? We can act on increased hepatic resistance by treating the etiological cause of the liver disease, or we can act with carvedilol, which is a non-selective beta blocker with an alpha-1 antagonist effect, so it will decrease hepatic resistance, or we can place a TIPS. We can also act on the extrahepatic territory with non-selective beta blockers, reducing splanchnic vasodilation or decreasing hyperdynamic circulation, and so decreasing portal blood flow, or with other vasoactive drugs, somatostatin and analogs, vasopressin and analogs like terlipressin, for instance. Or we can directly act on the varices by endoscopic therapy, different strategies, or also by transvenous obliteration. So we are going to look at the different scenarios and see how can we help these patients. First, pre-primary prophylaxis. So what can we do with a patient with portal hypertension that still has not developed varices? All patients with cirrhosis, and this is the Baveno 6 recommendations, should be screened for varices at diagnosis. This is very interesting because in patients with FibroScan of less than 20 and with more than 150 platelets, they have less than 5% chance of having varices, so we can avoid endoscopy in these patients. The cause of liver disease, of course, should be treated. Do we have to do something more in these patients without varices? There is no indication up to now to use beta blockers to prevent the formation of varices. And this was demonstrated years ago in this study with a very long-term follow-up with one arm of placebo, the other arm of timolol, where there were no difference in the probability of remaining free of varices. Now, this study included patients with no clinically significant portal hypertension. Almost half of the patients had less than 10 millimeters of mercury of portal pressure. So, of course, beta blockers are not going to give benefit on those patients since vasodilation is not present yet. So, let's move with a very recent study. In this study, which is not still published, will be soon, published soon in Lancet, this group studied the potential beneficial effects of beta blockers in patients without varices, but with clinical significant portal hypertension. They measured portal pressure in all patients, and then the acute responders to propranolol, they indicated propranolol, and the others, they indicated carvedilol, and they followed these patients for a long time. And they saw the development of varices, but also that were treated with band ligation, but also other complications of cirrhosis. And very interestingly, they saw that in the beta blocker group, the clinical decompensating events were reduced markedly, and for instance, ascites was reduced to 50% of the patients. So patients without varices, but with clinical significant portal hypertension may be benefit by a treatment with non-selective beta blockers. What can we do in patients that do have varices to prevent the first bleeding episode? All these patients, by definition, they have clinical significant portal hypertension. Patients with medium or large varices have to receive primary prophylaxis, as well as patients with small varices, with rail well signs, as well as patients with that are decompensated and have small varices. The reduction in more than 10% of the HBPG induced by beta blockers is associated not only with a decrease in the development of varices, but also, as we said before, with the decrease in decompensation of the cirrhosis. So this is a main point when treating these patients with beta blockers. So we are not only preventing varicose development, but mostly we are preventing decompensation and death. Either non-selective beta blockers or band ligation, one or the other, can be used to prevent varicose hemorrhage in these patients, and the selection of these treatments will depend on the patient characteristics. In cases that NSBB have to be discontinued because of intolerance, we can, of course, switch these patients to carvedilol. And because varicose ligation is a local therapy, patients have to be followed up when varices are eradicated to see if they have varicose recurrence. Let's move now to the treatment of acute bleeding. We have a dozen of recommendations in these patients. Of course, some of them are stated a long time ago as ICU, placement of the patient, ABC, intubation. Very important, we have, again, to stratify patient, which patient we have in the ICU. Antibiotics, very important, I will say something about that. IV vasoactive therapy. Blood transfusion to lead hemoglobin from 7 to 9. No recommendation up to now to correct coagulopathy. Rapid endoscopic therapy with band ligation, ultrasound, possibility of a balloon or possibility of endoscopic stents, and the possibility of TIPS. Even with this, despite these recommendations, much of these are not done. You can see that sclerotherapy is done still in many centers, or no endoscopic intervention, maybe because they have no these tools, but everybody has antibiotics, and antibiotics are administered in only half of these patients. An early TIPS in a recent study has been shown to be placed only in 10% of patients that had indications of early TIPS. So let's go a little bit with these points. 5-year mortality then is very different depending on the characteristic of the patient. If the hemorrhage occurs as an isolated event, or if the bleeding occurs together with other complications of the cirrhosis as ascites, encephalopathy, infections, etc. These patients have a very high mortality, over 80%. Regarding infections, years ago, there were identified patients at risk of having infections with more severe cirrhosis, and these patients have to be more protected with ceftriaxone and not with norfloxacin. Very recently, it has been suggested, taking into account the probability of multi-resistance bacteria in the institution or in the patient that has been hospitalized in other institution, that maybe we have to escalate to a more potent or higher spectrum antibioticum indication. But this is not still in guidelines. Regarding the vasoactive treatment, we have 3 options, terlipressin, somatostatin, and octreotide. And this elegant study have shown that they are, the 3 of them, they are the same, given by 5 days, concerning the control of bleeding, the mortality of these patients, and the 5-day treatment success. So you can use one of these 3 and indicate as soon as you can. Regarding endoscopy, band ligation has been shown to be superior to sclerotherapy, so is the recommended treatment to do also as soon as you can. Even with those treatments, vasoactive and endoscopic treatment, about 15 to 20% of the patients will keep on bleeding, and mortality in these patients is very high. So we have different possibilities, repeat, depending on the patient. Repeat endoscopy and treatment, or use a balloon or a stent, or maybe place a TIPS. Let's see how can we... Everybody knows the tamponade. We have used it. We use it in many centers in Latin America still now, but we know that it's associated with complications, and we can place a balloon for no more than 24 or 48 hours. So this has been replaced in many centers by fully covered expandable metallic stents, which are easy to implant, more easy than the balloons. They are effective, they are safe, and the advantage is that they can be left over 7 days in these patients. So they may be a real bridge to TIPS or to liver transplantation. These are the stents, you know them already. There was a study with a very few number of patients, but that demonstrated in favor of stents, more success of therapy, more control of bleeding, less infusion and less adverse events, and less necessity of TIPS when compared with the balloon placement. This study did not show any effect on survival, but there were very few patients. Then we have TIPS. TIPS have been used for rescue since 20 years now. So when everything fails, we have TIPS, and we can use a TIPS. And TIPS is very useful to control bleeding. Of course, in 100%, it will control bleeding. But the problem has been that TIPS has been indicated too late, when everything fails and the patient, mostly severe patients, are already in multi-organ failure. So mortality with TIPS in this indication, with this strategy, has been very high, from 30, 40, 50% or more of the patients. So the question has been in this last years, should TIPS be placed earlier in high-risk patients? And this was explored in this first study, which was published about almost 10 years ago, showing that in patients, child B with active bleeding, or patients child C with child score equal or less than 13, the placement of an early TIPS, that means in the first 72 hours versus standard medical therapy, was significantly better in the control of bleeding and also in survival. So the early placement of a TIPS in these specific patients has been recommended in the last guidelines and consensus, and it was recommended in the last Bavino conference. But it is well known that criteria for the patients should be, that was only one study, criteria should be refined. And therefore, there were other studies, like these very recent studies, that also showed that in patients with child C, early TIPS were very effective and should be used. But in patients with child B and active bleeding, this was not very clear, at least not in this study, which had more patients than the first study. And there was another recent Asiatic study that also questioned that it is useful and beneficial in child C patients, but we should refine the indication in child B patients, where probably it is useful in some of the patients and not in others. Then we have the prevention of recurrent bleeding, and this is first-line therapy is the combination here. You have to give both non-selective beta blockers plus endoscopic band ligation. And covered TIPS is the treatment of choice if this treatment fails. This is very clear. And because carvedilol has not been compared to current standard of therapy in this population as a secondary prophylaxis, its use cannot be recommended for prevention of rebleeding. I want to say something about statins, because there are recent studies also with statins in this population of patients. Simvastatin has been shown to be effective in decreasing death and with no change in rebleeding. And again, this is associated with a decrease in the decompensation of these patients. Simvastatin is given on top of standard of care, so on top of pharmacological and of endoscopic therapy. Also here, you can see another recent study where death and decompensation was reduced by statin use. We still don't know the exactly characteristics of patients that will benefit from this, and the doses, which are quite low in these studies, but this is very interesting to keep on research on this issue. To finish, a couple of issues with beta blockers. Two issues are their use in refractory ascites and their use in decompensated cirrhosis, which are not refractory ascites. The first population of patients, this has been studied in the 3/3 studies. This is the second study, where they took 170 patients. Half of them were treated with non-selective beta blockers. They were all patients with refractory ascites. And what they have observed is that the treatment in these patients with non-selective beta blockers was highly associated with more probability of death, and was one of the highest independent predictors of death in these patients. So we don't have to use beta blockers in patients with refractory ascites. Probably they induce paracentesis-induced circulatory dysfunction, and patients with refractory ascites that are on beta blockers have to be shifted to band ligation. On the contrary, on decompensated cirrhosis, these treatments have a beneficial effect. As you can see here, patients treated with propranolol after the first bleeding, they have less rebleeding, less recurrence of ascites, and less SBP. So we can really indicate in these decompensated cirrhotic patients propranolol, and there are some background explaining the benefit of this medication in these patients. So these are my take-home messages. Cirrhosis should be managed now in 2 different clinical stages, compensated and decompensated, defined by the presence or absence of clinical complications. The identification of patients with cirrhosis and clinically significant portal hypertension is mandatory. Non-invasive tests will be soon of great help as diagnostic tools, for instance, the level of the measure of FibroScan. In patients with cirrhosis and CSPH, but without varices, the objective of the treatment should be no longer or not only to prevent varices, but also to prevent clinical decompensation. New data concerning therapy related to this issue, as I've shown you, is being generated. In patients with compensated cirrhosis, it has been shown that statins may lower the incidence of decompensation and lower mortality. Therefore, they might become an additional tool in the management of these patients. After an episode of acute variceal bleeding in patients at high risk of failure or rebleeding, and early tips may benefit selected patients, all child C patients and maybe some child B patients. And non-selective beta blockers should not be used in patients with refractory ascites, but of course they can benefit patients with non-refractory ascites. With this I want to finish. I want to thank first Didier Lebrec, which was my first master, the father of non-selective beta blockers therapy in portal hypertension, and also, of course, Richard Moreau, which was the father or maybe the big brother of this speaker, myself, on the optimal therapy in portal hypertension. And also thank my team. Thank you very much.
Adrian, come. So it is my pleasure now to present the next speaker, Philippe Mathurin, Professor of Medicine, Head of the Gastroenterology Department in Lilly's Corps, well known, and he was also a pioneer for liver transplantation in patients with severe alcoholic hepatitis who are resistant to corticosteroids, and we will be very happy to hear you.
Thank you, Richard, for this kind invitation. Thank you, Patrick, for inviting me and for this outstanding meeting. So I would say how it would look like in 2019. So just to tell you that we start because now we know that at early times that patients who are not responding to medical therapy are definitely the patients who need to be considered for any additional therapy. As you can see, using the Lille score, which you can you can calculate this score after 7 days of therapy. As you can see, those patients who are classified as non-responder have a very worse outcome. So definitely this was the first point where the French and Belgian clinicians start, because they do consider that those patients deserve to have new therapy. So another thing is that every time we are talking about liver transplantation, we always are talking about liver alcohol relapse, but we never consider that among those patients who are not who have been transplanted for non-related alcoholic liver disease, if you are looking at alcohol use before and after, there is no significant difference. Because every time I'm telling people are talking about alcohol relapse, just talking about alcohol use after liver transplantation, if you are considered the other candidate, you will have the same things. But the issue, which is very important, is that in alcoholic liver disease, you have a higher percentage of having heavy drinking behavior after liver transplantation, and this behavior is associated with recurrence of the alcoholic liver disease and also increased risk of death at long term. So, and the second point that up to now, the center are relying on the 6-month rule, but definitely where are the data? I just want to show you that this criteria in terms of statistical weight when you are looking at only as a statistician issue, as a statistical issue, this is a ROC curve of the sober period before transplantation. It's completely irrelevant because this area of the curve is close to the fact that you are launching a coin in order to get an answer. And why? Because always we make the point. It's a very good inclusion criteria, meaning that when a patient is having more 6 months of sober period, definitely the risk of patients, the risk of relapse is very low. But conversely, it's a bad exclusion criteria, meaning that you cannot exclude a patient with this type of criteria because the patient has a 60% probability of being sober after liver transplantation. And just to show you that, in fact, it takes a while, but when you go to the tribunal, to the justice, I can tell you that already we have the answer for a long time. In 86, a person sued a liver transplantation in the United States. And look at what was the answer from the judge. He said, it's high operative, may not survive, but without enough 6 months evidence, expert opinion. So meaning that the court said it's arbitrary and unreasonable to use a 6-month period as a criterion for liver transplantation. And this is why when the French Conference of Consensus, I think it was a starting point, the jury state when they look at the fact that now we are able to predict at early times that the patient had a high risk of death. The jury states that the wait and watch strategy using this criteria is unfair for those non-responders, and they recommend pilot study evaluating early liver transplantation in non-responder. This was a key point because this allowed the Belgium and the French center to move on and to perform this early liver transplantation in patients with severe alcoholic hepatitis not responding to medical therapy. And this, always I quote this study on the behalf of the other colleagues because those guys were crazy enough to follow this idea. But they were very strict at that time. What they did, they said, we're going to perform liver transplantation only in a patient who have his first liver decompensation event of liver disease, meaning that this guy came at the hospital with a dead hand without having known that, been aware that he have liver cirrhosis. Non-responders were used by the LIS score, but also by the worsening of liver function, because as any score, this score may fail. A patient may be classified as a responder, but when you look at responder, generally speaking, their biological function are improving over the time. And when a patient is classified as a responder and you start to have a rapid deterioration of the liver function, it means that the LIS score is not effective. So you have to use both aspects to consider the guy who's going to die. And there are drastically selected absolute consensus, social integration, supportive family member, and psychiatric evaluation and addictive profile. And in fact, we use a kind of decision circle, which is up to now still ongoing in the French Center. So you have the family circle. And what we did think is very important. When this family circle, meaning the relationship between the patient and his family, is broken, I don't consider that you can go further because it will be very tough to handle the patient after liver transplantation. Thereafter, the senior in hepatology will come. So therefore, this evaluation is generally performed by the resident, the nurse, and the other person who are there. And therefore, this is where I am coming, which I call the senior hepatologist. And you can see also there will be a psychiatrist. The psychiatrist, the addiction specialist, will make his own evaluation without interfering with the team. And then after that, the surgeon and anesthetist are coming. And after those 4 decision cycles have their own evaluation of the patient, we have a meeting, and then we decide whether or not the patient will be the candidate to liver transplantation. And as a consequence, in this study, as you can see, those patients were very sick with a LIL score around 0.9. As you can see, the maximum of the LIL score is 1. More you get close to 1, worse is your survival. And the MELD on first day of therapy was 30, and at listing 44, showing you that the patient is still deteriorating his liver function upon the time you are selecting this patient for this program. And as you can see, it was a simple answer in terms of survival. This is a patient who are not transplanted during the time of the study. And as you can see, there is a patient who are considered for early liver transplantation. As you can see, the outcome, you multiply by 3 the probability of being alive 6 months later. And one thing came to this study that the fact do you have to choose your control, but the control were chosen at that time by the physician. So therefore, what we did, we performed a selection using a software who pick up in the database of Lille and Brussels all the patients, and therefore we are able to match those patients on pre-established range of age, gender, matter function. And at that time, we decided also to look at the same patient, and the only thing will be different, those patients will be responders. So this sub-analysis allows us to show one interesting thing, is that you switch completely the outcome of a non-responder using early liver transplantation to the outcome of a responder. Like the guy you shift completely is spontaneous behavior who will be there to an outcome of a responder to therapy, to medical therapy. So the issue that has been pointed out just before by Nora, which is very important, and I think it's not infection, it's Aspergillus infection. And when you look at this, it is very important, at least in our center, in the French center, we are facing the issue of Aspergillus infection, and I'm suggesting more and more that probably we need to shorten the steroid as much as we can. And I do think also in the most severe patient, we can also not, I think we may not use a steroid in those patients. I will show you this later on. But definitely Aspergillus infection is an important one. And this need to be carefully investigated before liver transplantation. And as you can see also, MEL score, and all those patients had a MEL score higher than this cutoff, are an independent associated predictive factor of Aspergillus. In terms of relapse, this study observes that 3% who relapse. None of them relapse on, I would say, heavy drinking. Even 2 remain daily consumers. And therefore, this study was considered as relevant enough to be at least tested in other centers. In terms, every time people are talking about burden, how much graft you will consume on this indication, as I can tell you, at least in our end, it's few patients. Few patients have been considered for liver transplantation in alcoholic liver disease. When you look at this very strict selection process, and as an example, in our center, 2% only on the global cohort have been currently selected for early liver transplantation. So, do organ donation will be affected by early liver transplantation? So, as pointed out in a very interesting review on the ethical issue related to early liver transplantation, he said that the use of liver transplantation may negatively affect the public attitude on transplantation and organ donation. This needs to be tested, and we'll show you one study at least who did that. It may cause reluctance to clinicians, the part of clinicians to modify guidelines, because definitely guidelines may be modified according to this type of selection. But I think it's our job to inform the public that the patient with self-inflicted disease were on the same access to medical research as other patients, because as an example, we always talk about obese patients, but don't forget obese patients, most of them are behavior-related disease. So this was an online survey which was distributed using an Amazon web service. A very interesting study from in the United States. So they put the survey population was a very important one, around 50 and 500 patients. So those patients were well balanced. The race ethnicity are the representative of the race ethnicity in the United States. And that what they did, they look at those patients who are considered as they have never been involved in liver transplantation, but they are potential candidates for organ donation. And this is to tell you that those patients were the global distribution of organ donation in the United States. Make it a short story. They asked them, what do you think about this early liver transplantation program? Only 18% of them said they are completely disagree. But conversely, 30% were neutral or agree or strongly agree. So does it mean that early liver transplantation seems not to affect the public who are the candidate for organ donation? And the thing which is very important, which I think it will depend on the country, because in the United States, good financial stability is an important one. In France, it's not, because as you know, Social Security is taking all the expense. and good social support, which is not also so important for us, but at least in the United States it's important, but age is important. And as you can see, younger age is an issue because younger age is associated with a high risk of relapse of alcohol and particularly in a heavy drinking behavior. But one thing I want to raise now is that now it's time that the scientific society need to model their guidelines according to data. Just to show you, this is where we start in France. This was from the group of Didier in liver transplantation. They look at the practice of the French center. As you can see, before the study, there is a switch because most of the center, which was not involved, most of them now did perform, and it's going up upon the time. And also this, as I said, challenged completely the rule of the sober period rule. As you can see, now 29% are using only 1 to 3 month abstinence rule. And therefore, this also will probably change, as I said, the selection of the patient in the near future, particularly the patient with ACLF. And as you can see, addictologists are very involved in our center. And after this study, most of them now have been involved before transplantation, after liver transplantation in the selection process. And I think it's a very important issue. Let's look one country by one country. German, it's a very tough thing because for German, for being candidate to liver transplantation, you have to be abstinent. You have to be this abstinence must be proven by at least 2 negative tests during the 6 months. And a positive psychiatric assessment is mandatory before listing. So for being a candidate in Germany, it's quite complicated. And after that, they update their guidelines in Germany. But look at what they said. Exceptional case may be considered, but you need to address to a committee of specialists of that at the Bundesarzt-Telkammer. I'm sorry about my German pronunciation, but never, what does it mean? It means that you have so much things to do that the guy is already dead, and therefore they are not performing liver transplantation because the time to transplantation has to be at an early time. Italy, they just move away and they adopt, I would say, the European statement and the French statement. And the UK, as usual. So before Brexit, do not worry. Before and after, everything is open to discussion, as you know, including early liver transplantation. But nevertheless, before 2014, it was listed as an absolute contraindication. But after that, the NHS allows the UK center to perform liver transplantation in severe alcoholic hepatitis. And I do think that Neuberger, who was the leader for this experiment, I think he told a good thing. He said that we transplant human, not angels, and therefore we don't have to think about behavior of patients. So now, at least the European guidelines on alcoholic liver disease strongly recommend early liver transplantation for those patients who are highly selected with severe alcoholic hepatitis not responding to medical therapy. And the Canadians are against it. Just to show you, they clearly said that you cannot perform liver transplantation even in the case of severe alcoholic hepatitis. So up to now in Canada, you cannot be considered as a candidate. Conversely, in the United States, it changed. And the first paper who came out was a paper from him, who clearly shows the same things than us in terms of outcome. And this has been already stated by Nora. As you can see, the number of early liver transplantation in United States is going up, and also the number of transplant units who are doing this procedure. And this probably comes from the evaluation of the group of Nora and Lee. And this has been an accelerated study, it's a retrospective study, but nevertheless, this study clearly shows that the outcome of patients is very good, and the use of alcohol are very limited as compared to what we are observing to the patients who were selected with the 6-month rule. The relapse rate is around 30% at long term. And which is different than we are observing, is they observe that the relapse in alcohol is associated with a worse outcome as compared to those guys who are considered without alcohol use and those with alcohol use. And in our experience, we don't have that result in our study, and I will talk about this later on, probably due to the selection process. So what was associated with death, as I mentioned, it was any alcohol use post-liver transplantation, but again, we don't have this result in our cohort. So we need to improve selection. Definitely, I think we need to select the complete non-responder. We call that in Lille the null responder, using the a new cutoff of the Lille score at 0.56, which is more restrictive. But I do think the best way is to combine the thing. Let me explain one thing. If a guy is coming to your unit with a MEL score around 36, the only way to bring him down to this type of mortality is liver transplantation. Because for going to this risk of death, the guy had to have a Lille score around 0.15. If you go to bring this guy around 10% of mortality, you have to have a very, very low Lille score, and I can tell you, according to the severity of the disease, you will never be able to do it without liver transplantation, at least nowadays. So this is why also to confirm, as usual, you need to confirm. So this is a confirmatory study. It was a protocol that was funded by the French Health Agency. So this study was the following. We use a control group for liver transplantation, where the classical selected with the 6-month criteria. Those guys were compared to the patient with not responding to medical therapy. Those guys were selected using an algorithm score. It's a reproducible algorithm score. If the guy was a woman was higher than 220 of score, he was selected. The guy with this score was not selected. The primary endpoint is the study is non-inferiority in terms of alcohol relapse. The secondary endpoint is survival benefit. As you can imagine, it's not a blinded study. We already have the answer. We just show again the benefit, and this paper we present, I think, this month. And this is where the team is doing the algorithm, because as mentioned, is a decision circle. So in conclusion, after first episode of alcoholic hepatitis, early transplantation may be proposed in non-responder, as most deaths occur within 2 months in the wait and watch and wait strategy. We need to confirm this result by other group, and I do think that the data from United States are quite encouraging, and I think the Italian group will present their data. We need international database to collect information, survival and addiction, to provide more facts and less conjunctures. And I do think that the PHC quick translation, which is finished, by the way, we are just now closing all the analysis, and I do think this study will provide a robust algorithm for the selection of the patient. Thank you very much for your attention.
We have very few time, one question per speaker. And I didn't see any question in the audience, unless somebody raised the hand now. So, yes, Dr. Terreau.
Yes,
you have a mic?
Go to the micro.
Do you go? Yes, go to the mic.
The alpha pump. So this is sort of a new thing. And I'm wondering, has it been evaluated, though, in anybody who has a higher MEL score? Are we going to be faced with the same challenges as TIPS? Because you raised it as a potential option for the patient with refractory ascites who's not a TIPS candidate. But I noticed that the study really is doing it in patients with low MEL scores. Can you speak to the issue of kind of the sicker patient? Is it going to be an option?
Tips in patients with a high MEL
No, the
score?
alpha pump.
Alpha pump, oh yeah.
Yeah.
It does not seem to be a problem. It needs general anesthesia, but high MEL score does not seem to be a contraindication for alpha pump, except perhaps that we should be cautious with kidney function. We need more experience, because it seems that patients with a high MEL score frequently have higher creatinine levels, and it seems that patients who are placed on alpha pump have an increase in serum creatinine in the beginning. So whether alpha pump can precipitate some sort of AKI in patients with a high MEL score is a possibility, but otherwise it seems that it's not a contraindication for alpha pump. And if patients are candidates for transplantation, by definition, they are candidates for a minor surgery such as alpha pump.
Okay. One more question. I have a question for Adrian Gadano. You alluded to the use of statin, but I'm a little bit worried about the safety of this drug. Do you have any comment about this?
Yes, there is also always a perception of that statins may be harmful in patients with severe liver disease, and and I share this. I think that the safety has been to be studied further. Yesterday we discussed with Jaime Bosch in the session, in the workshop, which dose in which patients, and this is not clearly defined. So further studies.
Okay, thank you. Maybe you have questions. I have a question for Philippe. Yes, for sure, there is a room for early liver transplantation in selected patients with severe alcoholic hepatitis, but what about those patients who are very severe, who have ACLF grade 3, for example? What is your advice? What is the limit? Do you have an answer for this?
We don't have limit. We don't have limit because we have a paper that has been presented. It was a triple experience from Paul Bruce, Montpellier, and Lille. The first author was Florent Truch, showing that at least in this well experience in CLF, we don't have any over high risk of mortality in those patients. So when a patient with early liver transplantation is coming CLF free, meaning renal replacement, ventilation, what we did, now we are not using steroid in this patient because we consider that there will no way he will respond to the therapy, and therefore if the guy is a good candidate, we'll put him on the waiting list using this algorithm score in order to select him. Because I forget to mention that the algorithm score was also designed for encephalopathic patient and non-encephalopathic. So encephalopathic, at that time, the selection will rely mainly on the family surrounding the patient.
Thank you. I think that we should close this session. Thank you for two speakers, and thank you to the audience.